Thank you all for joining us this evening. This is a BCH symposium dinner on heterotaxy syndrome. My name is Vivian Nasser. I am the Chief of Cardiac Anesthesia at Boston Children, and I have the pleasure and honor to be working with all the colleagues who are going to be speaking today about heterotaxy. We're going to start with the first speaker. It is Dr. David Schidlow. I'm going to invite all three speakers, actually, for the first session to come up. Dr. David Schidlow, Dr. David Hoganson, and Dr. Reena Ghosh. Dr. Schidlow is a pediatric and fetal cardiologist, a cardiac imaging specialist, and the director of the Heterotaxy Program at Boston Children. He's going to be presenting the program for this evening and then talking to us about hope for heterotaxy and multidisciplinary care in a complex world. Thank you, David.
Well, thank you for that lovely introduction. It is such a pleasure and an honor to be here and to share our institution's experience with heterotaxy with colleagues from my former home here in the DC area, from across the country and from around the globe. Just a moment to acknowledge our symposium planning committee. That was Drs. Baird, Bloom, Da Cruz, Amani, Nasser, and myself. Thank you for all the work that has gone into preparing the symposium. And I also wanted to take a moment to acknowledge our amazing marketing team, particularly Casey Powell and Liz Swanson, for making sure that every detail of the symposium has come together so beautifully. Just one quick note. Unfortunately, Dr. Amani had to be in the operating room today. So Drs. David Hoganson and Eric Fines have graciously stepped in on his behalf. So with that, hope for heterotaxy, multidisciplinary care in a complex world. So my objectives are to explain the need for a multidisciplinary approach to heterotaxy, to introduce the Boston Children's Hospital heterotaxy team, and share some of the important elements of the multidisciplinary heterotaxy assessment. So why heterotaxy? Well, anyone in this room who takes care of patients with heterotaxy is familiar with the level of complexity. These are just a few recent patients. On the left, a patient with polysplenia, an unbalanced canal who required a Norwood and then was discovered to have biliary atresia about 2 weeks post-Norwood. In the middle, a fetus with polysplenia, a balanced canal, L-loop transposition, congenital heart block requiring premature delivery, also with malrotation and duodenal atresia. And on the right, a patient with asplenia, dextrocardia, a balanced AV canal defect, double outlet right ventricle, pulmonary atresia, ciliary dyskinesia, and malrotation. So it is no surprise that this is a complex and difficult patient population to care for. And as our experience has shown, this is a patient population, the prognosis of which has been a challenge to move the needle over time. We also take care of a large number of heterotaxy patients. On the right, you can see this is a little bit of a tracker that we have that shows the number of patients that we care for locally, regionally, and then a number of patients on a national and international basis. Those are unique patients per year. There can be same patients from one year to the next, though. So those of us who care for these patients are often left wondering how the different abnormalities interact to affect the overall well-being of a child. Would a multidisciplinary approach be helpful in caring for the child? And what is the overall best management strategy? And this does require a little bit of a shift in thinking from one that, let's just say, is very cardiac up in front, to one that is more balanced in its approach and one that requires the input of other individuals throughout the hospital. And so with that, this is our heterotaxy multidisciplinary team. Each one of these individuals has a particular interest in Heterotaxy and being their institutional and departmental champion for their specific subdivision. I won't read every name. This is being recorded, and you'll have access to this later. But suffice it to say, we have representatives from all over cardiology, from within pulmonary, cardiovascular genetics, gastroenterology, surgery and radiology, immunology, neonatology, and neurodevelopment. Our mission statement is that we recognize that heterotaxy is a complex and multifaceted syndrome affecting multiple organ systems throughout the body, and the heterotaxy team provides comprehensive, multidisciplinary care to infants and children with heterotaxy, and that includes screening, management, intervention, and follow-up with the hopes of optimizing outcomes. So what follows is just a brief overview of some of the things that we do in our heterotaxy program. Many of you in this room are familiar with the fact that many patients with heterotaxy, particularly those with asplenia, but some with polysplenia as well, have ciliary dyskinesia. And in these patients who, for example, undergo single ventricle palliation and require low pulmonary vascular resistance, or who are undergoing multiple procedures, certainly ciliary dyskinesia can be an important part of their care and their outcomes. So for these patients, we do a routine screening for ciliary dyskinesia. That includes a nasal brush for cilia structure by electron microscopy. For older patients, nasal nitric oxide. Frequently, these patients are identified to have gross anatomic abnormalities as well. And one of our aspirational goals for the program is to make sure all of those who do have cilia dysfunction have an airway clearance regimen preoperatively and postoperatively. In terms of the immune perspective, as I have learned from my colleagues in immunology, the immune function in heterotaxy is so much more than spleen yes or spleen no. So our patients get a thorough immunology evaluation that includes an abdominal ultrasound, a peripheral smear for Howell-Jolly bodies, a pitted RBC count, for some spleen scintigraphy, immunoglobulin titers, and flow cytometry. And then as far as management goes, we essentially assume that all patients with heterotaxy have functional asplenia until proven otherwise. We make sure patients have appropriate vaccinations and fever guidance, and for those that need it, a replacement immunoglobulin therapy. The feedback from families has actually been tremendous, especially with regard to the immune portion. It is really kind of surprisingly a wild, wild west when it comes to especially supplemental vaccinations. So we're very happy that's something that we're able to provide at Boston Children's. As far as genetics goes, we know that about 40% of the time we can identify an underlying genetic abnormality. Those can be spontaneous mutations or through variable inheritance patterns. And this can really happen at virtually any point in the pathway that establishes normal-sidedness. And so we make sure that from the get-go, patients have a genetic evaluation. At a minimum, that is a gene panel, but for many, that extends to become a chromosomal microarray or whole exome sequencing. From the gastroenterology hepatology perspective, I think it's important to share that at the moment, current data do not support routine malrotation screening or prophylactic LAD, and that is supported by a recent guidelines paper that came out within the last year. When enteral surgery is planned, we do have the surgeon review the risks and benefits of a LAD with the primary team. Of course, without routine screening, family and provider education is very important. On the other hand, for biliary atresia, which certainly can come up in patients with polysplenia, we do make sure that all patients have a direct bilirubin assessment to make sure that we are not missing this very important abnormality. So with regard to the heart, you're going to be hearing a lot about our cardiac care over the next several talks. But I do want to mention that the Heterotaxy program is very well integrated and essentially would not be the same program without our interactions with the biventricular repair team, without surgical electrophysiology, and without 3D modeling. We are fortunate as well that we have a research registry, which we are capturing not only cardiac but non-cardiac data as well, so that we can get a more robust understanding of children with heterotaxy, to understand some of their nuances and hopefully drive outcomes. I do want to acknowledge one of our former fellows, Dr. Emily Buchholz, who was really the driving force behind this registry. She's now at Children's Colorado, but she remains very involved up until this time. I also want to acknowledge our heterotaxy team leadership. I'm the one speaking, but also David Hoganson, who is the co-director from cardiac surgery. And also, a little more than a year ago, we were fortunate enough to hire Caitlin O'Connell, who is a nurse practitioner with a tremendous amount of experience within the Heart Center, who has really been just terrific in terms of being the glue that holds our program together. And she is often the face of the program to families that are reaching out from the Boston area and beyond when they first contact the Heterotaxy Program. I would encourage you, if you are so inclined, to check out our website. One can Google Heterotaxy and Boston, and this should come up. And then you can use the link to contact us directly. And certainly you can feel free to point your patients to this as well. So again, thank you so much for this opportunity. It was a real pleasure. Feel free to reach out, and I'll turn it over to Dr. Nasser. Thanks.
Thank you, Dr. Schidlow. We'll take questions after the second talk. So the two speakers actually are giving the second talk. It's Dr. Hoganson, who you already have been introduced as the co-director of our Heterotaxy program. He's a pediatric cardiac surgeon at Boston Children. He leads the 3D modeling and simulation program within the Heart Center. And then Dr. Ghosh is a physician scientist in the Department of Cardiac Surgery. She's a member of the Hoganson Hammer Lab. She's trained in pediatric cardiology and advanced imaging and focuses her efforts on valve modeling and clinical application of novel imaging and segmentation technique. Even though I don't get to see Dr. Ghosh a lot, but I see all the imaging that she does helping our surgeon intraoperatively. So here you go.
Great. Well, thank you. It's a privilege to be able to share with you this evening about how we're using 3D modeling and simulation for preoperative planning in heterotaxy syndrome. And I'll present a little bit, and then Reena will show some fantastic modeling of the mitral valve. So about 6 years ago, we put together a 3D modeling and simulation group within Boston Children's Heart Center. I have a background in engineering, and I teamed up with a very brilliant PhD in mechanical engineering, Pete Hammer. And we've assembled a team of professional engineers that create 3D models for our heart center patients used for preoperative planning in the OR as well as the cath lab. And this engineering team uses the best available tools from aerospace and automotive industry to do patch planning and computational fluid dynamics, which is flow simulation for some of our patients. And we really have offered this service almost as a consult service for the Heart Center for any individual who has a complex patient that could benefit from this. And over the last 6 years, we've created over 850 patient-specific 3D models that have been used for our patients, including many of these complex heterotaxy patients. We use an all-digital platform. Years ago, we used to 3D print hearts. We stopped that a long time ago, and now we have an all-digital platform. These are shared among the Heart Center and a web-based viewer, as well as used in the operating room. This is a 3D model of a complex heterotaxy patient who has unbalanced AV canal. This is the third patient-specific model that we've made for this individual patient as they've gone along their journey. They obviously have dextrocardia and the left dominant AV canal. And this is modeling we did prior to a complex 1.5 ventricle repair, which we use a 3D model to plan the surgery as well as the LV to AO baffle pathway we made inside the right ventricle. This patient had a very nice result and is about to be discharged from the hospital. And so the overarching workflow we have is we start with a 3D a CT scan or an MRI, and from that our engineering team can make a segmented model of the patient's individual heart, and then that digital model serves as sort of the baseline for a number of workflows. We can use the model in and of itself for preoperative planning and intraoperative guidance. We use it as a basis to then, within engineering software, do virtual surgery to plan patches or baffles, and then also for flow simulation for our complex single ventricle patients to understand the best option. And certainly heterotaxy patients span the entire range of that. Because we use a web-based viewer for these digital models, we're able to bring the models in the operating room and have them up on a screen. And we actually reprogrammed a Nintendo Switch controller for those of you with small children. And it sits in a sterile bag on the operative field, and we're able to manipulate the model from the field. And it's been extraordinarily useful in these really complex patients. And Dr. Fines and DeWitt in a bit will share with you more about our intraoperative conduction mapping service, but that also uses these 3D models. So we have a number of workflows that we do for these complex patients. One of them is quantitative reconstructive planning, where we can plan patches or baffles. And it's really important to plan these on the heart in the state which it's going to be, which is filled and pressurized, and not empty and flaccid, which is the way we're typically used to it as surgeons, of trying to craft a patch, which really has to work in the heart's in its pressurized form. So we're able to do that with great precision. Also take into account the mechanical properties of the patch, and then use complex math to create the flat patch equivalent of those curved patches, and then import that plan into the operating room with an intraoperative laser system. And this is an example of a patient with double outlet right ventricle and a large conoventricular VSD who required an LV to AO baffle as part of their repair. And you can see here, looking inside the heart, the purple is the right ventricle, and the little green outline is on the VSD. And you can imagine a pathway from the VSD up to the aortic valve. And we're able to plan that, with software and virtual surgery to plan the patch to create that baffle. And then with this aerospace software, we're able to then flatten that patch to create the flattened equivalent of that curved patch, which is not something you can do in your mind, and then take that flat patch equivalent into the operating room. We have a laser system, which we stole from the aerospace industry. They use all the time, where they project the plan down onto a laser, an airplane part they're trying to put together. And so we're actually able to project the plan for the patch in a sterile way onto sterile patch material, and then trace it out and cut it out. And we just published our validation study for this, demonstrating less than 2% error between the planned patch and after it's traced out and cut out. So it's really going to allow us tremendous precision in these complex repairs. We also use flow modeling in complex single ventricle patients, where we take the 3D model, we model different surgical options, take the patient's hemodynamic data from cath and MRI, and are able to simulate the flow through different options and understand the best option for our patients. This is an example of what this looks like. This is a 21-year-old heterotaxy patient who had a Fontan completion, has all their hepatic venous flow going to their right lung. AVMs have developed in the left lung. We're able to show that with simulating several physiologic states, and then simulate a repair, in this case a hepatoazygous shunt, which achieved much better balance of hepatic venous flow. So really phenomenal step forward compared to just trying to base all these decisions on historic experience. We do MRI follow-ups on all these patients and have had phenomenal congruence between the CFD models, which in this series have predicted 51% of flow to the right lung, and a post-op MRI have shown 49. So really nice congruence. We have a large team that does this. We have 14 engineers, including Reena, who you'll hear from, who do the segmentation, the virtual surgery, in vitro validation, and it's really been quite an effort. So I'm going to turn it over to Reena, who's going to share with you about a really terrific advance in the last year about AV valve modeling in heterotaxy.
So AV valve modeling is critical in heterotaxy. It's central to preoperative planning, whether you're addressing valve regurgitation in a patient with single ventricle physiology, or whether you're considering a two ventricle repair. So some of the preoperative challenges we face are, one, understanding the adequacy and the orientation of ventricular inflow, particularly in the heterotaxy patients with AV canal defects. And two, understanding the subvalvar apparatus and how those structures contribute to the feasibility of ventricular septation. So within our valve program, we address these challenges by using high spatial resolution, CT or CMR-derived 4D datasets to create digital models of the patient's AV valves. Advances in CT technology, novel CMR imaging sequences, and new contrast agents allow detailed imaging in even the smallest patients. So the modeling is performed using a combination of segmentation tools from 3D Slicer and Materialize software. And the quantitative data is derived using the Slicer Heart extension. So in this video of a patient with a complete AV canal status post-repair, you'll see the pink structure is the aortic annulus. The yellow is the left AV valve annulus. The chordae are in teal, the left papillary muscles are in blue, and there's an accessory papillary muscle in purple. The composite anterior leaflet is labeled in its superior and inferior bridging leaflet components, and the mural leaflet is identified as well. Now also, as seen in this video, you can see that we can analyze various aspects of valve structure, including leaflet prolapse height, annular characteristics, and quantification of effective inflow orifice areas in 3D. So this is a case of an 11-year-old patient with heterotaxy, a right dominant AV canal with aortic atresia, and you can see the neo-aortic annulus in pink, and superior inferior ventricles, and she underwent a single ventricle palliation culminating in a lateral tunnel fontan. So this patient presented with progressive left-sided AV valve regurgitation, depressed LV function, and plastic bronchitis. So the question for our group was, how can AV valve modeling inform potential surgical repair of her common valve, and how can it inform anatomic feasibility of a ventricular septation? So manipulating the digital model in mid-diastole, we can evaluate both of the inflows. We can quantify effective inflow orifice areas. We can also visualize the subvalvar apparatus. And then here we can assess the orientation of those inflows with respect to the ventricular septum. Now, using the baffle planning tool that Dr. Hoganson mentioned and models created in systole, we can evaluate baffle options for the ventricular septation. So this modeling allows us to visualize structures surrounding the potential baffle pathways and allows us to evaluate feasibility and necessity of interventions such as chordal replacement, chordal translocation, or possibly splitting of the papillary muscles. Furthermore, if the proposed baffle is deemed to be the best option, then visualization of these surrounding structures really allows them to be used as anatomic markers for patch placement. So we're looking forward to next steps and future efforts, particularly in combining hemodynamic flow data with this type of anatomic modeling. Thank you.
Thank you. We have time for questions. There's 2 microphones. If anyone have a question, if you can come to the microphone.
My name is Toshi Yasuguchi from Japan. So I have a question. When you're making a 3D model, so what cardiac stages, the cardiac like cycles, the endosystole and the diastole, the morphology may change. So I think it's when you how do you decide, how do you determine dynamic changing from this 3D model?
Yeah, so we can model it both in systole and diastole. Often the it's either a cine CT or an MRI that goes throughout the entire cardiac cycle. So we can choose based on what we're trying to do, whether we're going to model it in systole, diastole, or sometimes both.
Well, sometimes the cardiac surgeon was just relaxing the ventricles. So I think it's maybe the dimension was changed from the live in the model.
Yes.
So
yes.
how do you?
Right, but the goal is for the patch to work best when the heart's working, not when it's deflated. And I think that's sometimes been the challenge as surgeons, is we're working with the heart deflated and in a different position. And then when it inflates, sometimes these complex LV to AO baffle pathways can kink or whatever, because we created them in a flaccid state. So doing that in a planning for the pressurized state can really be important, especially because we can take into account the mechanical properties of the patch with the the approach that we have, so that can really avoid other errors.
Okay, thank you.
So I have a question unrelated to some of the things you presented, is about the genetics, So I follow a very large Amish community, and I have a lot of patients with LS1 Crevaux syndrome, which are on the spectrum of heterotaxy. We have patients with, immotile cilia syndrome and complex heart disease. So my question is, in terms of doing genetics like CIROP mutation or what mutation is, can you do any genotype, phenotype correlations and some kind of predictions as to which direction the patient's going? Because I think that would be super helpful for us to know if we can do a genotype, even antenatal diagnosis, and say, well, this is going to be an unbalanced canal, this is going to be balanced, these lungs are not great, this is going to be great. Because the lungs become a huge issue, at least in my EVC patients, and they are a spectrum. It's the ciliary dyskinesia patients, right? So if the lungs do well, then you can take a lot of risk and do a single ventricle palliation. If the lungs are not good, you're stuck, So I'm just curious if you have invested in the genetic world a little bit to do some genotype, phenotype predictions and correlations.
That's a terrific question. And I think that we kind of recognize that as the holy grail, if you will, of heterotaxy is understanding the genotype-phenotype correlation. I think at the moment, the challenge is that for those that do have a gene identified, the phenotype can be somewhat variable to individuals with, for example, ZIC3 X-linked heterotaxy might have wildly different heart disease. And I think the same thing goes for ciliary dyskinesia as well. There can be those that have frank ciliary dyskinesia, whereas others may have a more subtle cilia dysfunction when they're only challenged with a surgery or something along those lines. But that is really one of the goals of the program, is to get genetic testing on all patients who come through the program, so that we can hopefully answer that question in some greater detail in the future.
Thank you.